Antimicrobial resistance, one of the top global public health issues facing humanity. So, what is it? Why is it a problem? What are the main drivers? And how do we prevent it?
Hello, my name is Abdulhamid Abatunde. I'm a medical doctor and a public health researcher. I've been practicing clinically in Nigeria for over a year now, and I've been involved in public health interventions, community outreaches, and research for over 5 years. My works relate to HIV/AIDS, maternal and child health, digital health, and AMR, antimicrobial resistance. The first time I heard about antimicrobial resistance was in 2018, and I got to know it through a senior colleague who was a pharmacy student at that time. So he posted about antimicrobial resistance in his on his Facebook page. He posted about the dangers of antimicrobial resistance, and at that time, what he meant to me was about the fact that when we use drug and it's not working again. So probably that's what it meant. So that was my first thing about it. That time I was still doing A levels. I was about to gain admission for to study medicine and surgery. My first encounter was within the first 2 months of practicing as a medical doctor. And of course, I've seen some experience while I was a medical student. And it shaped my experience about AMR by seeing the real life impacts of antimicrobial resistance. So for this particular patient, we noticed after we admitted the patient and started empirical antibiotics. So usually we ask for patients to do other investigations such as blood culture or microbial culture and sensitivity tests, and it came out to be resistant to the medication patient was currently on. That was on ceftriaxone. So because of this, we had to go for a higher antibiotics, and we started the patient on I think meropenem, so to be able to cater for this, and this is actually way more expensive, and it caused the patient to spend more money and stay longer on admission. There are many cases. One of the case of a child who had surgery and was expected to stay very short time on admission after the surgery for about 5 to 6 days. However, the catheter was passed at the course of surgery, so patient developed a urinary tract infection, and it was multi-drug resistance after the microbial sensitivity culture and sensitivity test came out, and was resistant to every drug except polymyxin B, which is definitely not readily available, and especially for children. I've actually not seen it before. So because of that, they had to look for a way to get this drug and compound it for the child, and which really impacted the child. The urinary tract infection made the clinical state of the child worsen because of the lack of drug that could actually combat it. So when we later got the polymyxin B and it was compounded for the child, it helped a bit improve, but it actually stayed very longer on admission, and with a lot of need to monitor the kidney function test regularly, and several other investigations that were done in order to ensure that the baby could recover and get better from the treatment. So generally, it caused there was morbidity because of the longer stay on admission and other exposure to nosocomial infection, and after getting the urinary tract infection is also like a nosocomial infection, and it cost them more money on admission stay, trying to do other investigations, and complications such as acute kidney injury, which were managed. And then it also caused a lot of stress for the parents because the child has to go through a longer admission stay, and it was not planned. And for the healthcare workers also, it gave people sleepless nights in order to ensure the surgery went very well. And definitely the beauty of surgery is to have a patient gets better immediately. So we had to stay longer, monitor closely, and in the end, we were able to save the life. Or there were people who sometimes might not make it from there, and especially the facilities are not readily available like it was in my center. One major problem is that patients, before probably they present to healthcare center, they've probably used a lot of medication at home, buying low quality drugs, and this is initially healthcare costs, and many of the time they might even have spent a lot all their money that they could have used for actual treatment when they later present to the hospital. This is the first cost. Then when they present to the hospital, we because of the long treatment on antibiotics, it gives a lot of challenge for the healthcare provider to know which antibiotics is next, because many of the time patient might not actually even know the name of the actual antibiotics. So we need to just research and try to know from the brand name and know which one they've used. So it costs money from there. Then money for running tests, microscopy tests and culture tests like blood culture and stuff. They are actually very expensive, and it takes a lot of time before you get the results. So initially, you might want to start empirically, and for patients that have probably abused a lot of drugs, you might want to go a little higher or use a good, a strong brand. For instance, for ceftriaxone, you might want to use Rocephin, which is more expensive brand, but it's, you can trust the quality to some extent. So many of the time it costs patients a lot of money, and when the results come out and we see that it's resistant to these common empirical drugs, you might want to go higher to meropenem, piperazine, tazobactam, based on the sensitivity, or even as high as using vancomycin. And there are some instances where patients might even be resistant to even the higher antibiotics that are reserved for special cases. So these are a lot of problems, and the fact that patients' relative, they are worried a lot because they are unable to see that the resolution of the symptoms, and the doctor are also telling them that the patient, the drugs, the organism is resistant to some of these drugs, so they have to go for a bigger brand. Sometimes it might not be available in the hospital pharmacy. They might have to order it from other places, which might be far and cost a lot more money. So these are a lot of socioeconomic challenges of antimicrobial resistance, and we experience this many times in the hospital. For healthcare workers, there are contributions of healthcare workers to AMR. For instance, in private facilities, you get to hear where people say they want to make money, want to maximize money sometimes. So there might be some healthcare practices whereby every patient is started on IV antibiotics in order to increase the costs. And also, patients also have some behavioral change, whereby patients think that until they are given antibiotics, IV antibiotics, they've not actually been treated. So when the doctor actually tells them, okay, what you need is probably to rest or to take paracetamol, down probably because of your to relax the fever, some patients will decline and we try to present to other places. Sometimes might not be to a trained professional, and they just want to get IV drugs and say in quotes they've treated malaria and typhoid, which is a very common occurrence. Also, like in healthcare facilities, a lot of times patients after presentation, everybody starts on ceftriaxone and IV ceftriaxone, almost every patient in emergency, which is a practice that is getting very common and may not be appropriate in sometimes, because there are a lot of causes of fever that are non-infectious causes. For instance, a patient coming with stroke, ischemia around the midbrain, probably the hypothalamus, and it's affecting the regulation of the temperature. Patients keep having 40 degrees Celsius. Of course, increasing antibiotics or loading the patient with high dose of antibiotics will not be like is not the actual treatment for the fever in this occurrence, or patient that probably is having deep venous thrombosis and there's leg swelling. So there is need for some adequate history taking and proper investigations before commencing antibiotics. Of course, antibiotics in our community, a lot of things are due to infectious causes, and people, so we need to do some empirical and prophylaxis for surgery and stuff, but we need to also be very careful to reduce the abuse of antibiotics, especially in emergency cases and for surgery. Because a lot of times, and that was one thing that was very interesting when I was in my training and my practice, whereby surgeons, if they, for instance, if the surgery is a very is a clean one surgery, proper sterilization with using antibiotics, and these are things that we need to uphold in clinical practice. One important thing that we need to know is that every drug is a poison except it is appropriately used. Drugs are not sweet, so we need to be very cautious. And for antibiotics, there are specific need for antibiotics and the number of days that we need to use it for. So we need to be very responsible and take our own, because we might be the one to bear the brunt of using antibiotics recklessly, because these bugs are also living organisms that adapt, and they tend to develop mechanisms to get better and evade our medication, and this is what causes antibiotic resistance. So it's a very big problem right now because a lot of bacteria infections are now superbugs that are resistant to common antibiotics, and it's very difficult to develop new ones. So my advice for the public is to avoid taking self-medication, avoid going over the counter just to procure antibiotics because you have fever or because you have a small wound, so you want to just start using antibiotics for it. So you need to try to present to a proper healthcare provider in order to get proper, adequate evaluation and be actually confirm if you actually need antibiotics. And in event that healthcare providers say you don't need antibiotics, you need to just accept that and follow the treatment. Also, it's also very important when we are prescribed with antibiotics, we complete the dosage of antibiotics. It's for 5 days. Take it for 5 days. Don't use it more than for 5 days if they say it's for 5 days. Some people tend to use antibiotics for 2 weeks, 3 weeks, and when it's not specified for that. So also you don't give, you don't share antibiotics. Okay, this was the one I used when I was sick. You to try to use it. It will help you. So these are major problems that we have. And there are even instances of people putting antibiotics into herbal concoction and buying on the streets. Let's be very careful with this, and also abusing it in our animals. So when people have like small poultry in their house, they just load them with antibiotics and end up eating the same animal. So we need to be very careful with this and not abuse the medication that we have, because if they don't work again, it's a big issue for us, and it might be difficult to actually develop newer antibiotics that will combat this. Apart from just bacterial antibiotics, we also have people using antifungal and triple medications such as soaps and creams that are triple actions, whereby it's antifungal, antibacterial, and anti. So we need to be very careful about this. You don't need to use a medicated soap or a medicated cream, or if you're actually not prescribed by a healthcare provider. So just use your normal beauty soap and you'll be fine. So we need to stay away from this subconscious and daily abuse of antibiotics and antimicrobials in our environment.